So we're back live for the Q&A session. Brittany's been manning the questions throughout the talks this afternoon, but we have some that we're going to present to our panel right now. All right, so this is going to be for Dr. Calkins. I've heard many times today that you recommend an ACE inhibitor if you have significant disease. I'm sure it's complicated, but how do you define that? As a general rule, does the LVEF have to be a certain percentage? You have to unmute yourself.
In general, I'm a great fan of ACE inhibitors. We have to recognize that there's been no official studies of ACE inhibitors in ARVD, but there's a lot of data in regular heart failure patients that they make a huge difference, and they tend to be not only do they prevent progression, they can also cause reversal of other types of heart failure. So I generally recommend it for patient, basically anyone who has a significant decrease in their LV or RVEF, and I'd say significant is 10% or more. If you say normal is above 55%. Actually, now that I say that, I'd say 50% or less, 50%, 45%. Certainly, if you see that kind of decrease, I would definitely suggest an ACE inhibitor. That doesn't mean you have to take it. Try it. If you're hypotensive and you have side effects from it, then obviously it's not worth it, in the absence of strong data. But I generally think in the absence of all the answers, it's best to take it, given that it's so simple, so safe, and has the potential to make a big difference. And we've shown that, almost half of ARVD patients will develop heart failure, if you follow them long enough. So this is a serious problem. That's one of the few things we can do other than restrict exercise.
Okay, Hari, this is probably for you. Is there a limit to how many epicardial ablation procedures a person can have?
I think that's a good question. In general, it's believed that you can only do it so many number of times before the pericardium closes off. But that really depends upon the quality of ablations. If you do an ablation where you don't let a lot of blood in the pericardial cavity, meaning if it's a clean way you approach it, then there is really no problem. You can come out of it and there is no scarring, there is no adhesions. But if the first time you go in or the second time you go in, if you cause a bloody effusion in the pericardium, then it kind of heals with inflammatory response and makes it impossible for you to enter the pericardium again. So I think if you do it right, there is no serious upper limit to the number of ablations that you can have. Well, the idea is not to keep having these epicardial ablations, but I'm saying that if there is no problem with accessing the pericardial space, if you do it the right way.
Can you also address some of the side effects one might experience after having a sympathectomy?
So sympathectomy has like two types of side effects. One that happens immediately after the procedure, and things that carry on in the long term. The majority of side effects of sympathectomy are things that happen immediately after. There's a lot of pain in incision sites. There's what we call orthostatic hypotension, because sudden loss of sympathetic tone causes people to be lightheaded when they suddenly start moving or standing up. And because you enter the lung through video-assisted thoracoscopy, it takes time for air to exit, the lungs to completely re-expand. So sometimes you end up spending a day or 2 or 3 in the hospital on a chest tube until the lung completely re-expands. So that's all the acute side effects of sympathectomy. Horner syndrome is very much talked about, where people get droopiness of the eyelid. We don't see that as a bigger problem because of the way we have changed the way in which sympathectomy is done. Sometimes you can get a transient droopy eyelid, but that resolves within weeks. The longer term side effects are mostly related to excessive sweating in the lower half of the body, called hyperhidrosis in the lower half, or compensatory sweating. That seems to happen in a very erratic fashion for some people. It doesn't happen to everyone, but for some people, they may have some excessive sweating in the lower half of the body, which is called compensatory sweating. And sometimes you can also get back pain, which is probably because of cut cutaneous nerves, and that can last up to 4 to 6 months. And these are the only side effects that we have seen in our population, and also in the review of literature of all the sympathectomies that have been done in the United States and abroad, overall, and as a broad category, these are the side effects we've seen so far.
Okay. This is, we're going to talk about Apple Watches and heart rate monitors. Do you think newer Apple Watches heart rate and EKG features are reliable for cardiac patients?
I think the Apple Watch, I think they are reliable. It's amazing the advancements in technology. The real question is, what is the value of monitoring your heart rate? And I personally, some physicians will tell patients, oh, you can exercise as long as you keep your heart rate less than 110 or 120 or 130 or 140. There's absolutely no data to show that in fact is true or is the case. Now we'll have Cindy comment in a moment, but we know that in terms of how much exercise you should do or shouldn't do, we know that 20 to 30 minutes of light to moderate exercise 3 to 4 times a week seems to be safe. And above that, we really don't know. And we know high levels of exercise are terrible. But the idea of someone thinking that it's fine to be out fast walking or bicycling or doing whatever, and if they keep their heart rate less than 110, they're going to be just fine. That's a nice idea. There's no data to support it. And you have to remember, most patients, or pretty much all patients with ARVD, are on beta blockers that slows your heart rate. So a heart rate of 120 when you're on a beta blocker may be associated with a very high level of exertion. So I don't think that's generally a good strategy. The heart rate guided exercise, I think, is a bad idea. But Cindy, you've spent a lot of time thinking about these questions. What do you think?
Sure. So Hugh, I think you summarized it really quite well. As you just said, we don't have a ton of data, but the data we do have is pretty clear that it's a combination of duration and intensity. So an exercise dose that sort of makes things worse, makes things more risky in terms of exercise. And just as you summarized, of course, maximal heart rate is going to differ depending on the medication you're on. So yeah, I basically agree with that. I am not the technology expert here, and so I'll leave it to the physicians to describe the accuracy of the ECG and such.
So someone had asked, their husband has one of these, EKG apps and really wants to know how accurate are they. So if it says unknown arrhythmia detected and you're feeling well, should you be concerned?
The answer, in my mind, the answer is no, you shouldn't be concerned. The Apple Watch, the EKG features on some of these systems it's reasonably accurate, but not terrible, not super accurate. You certainly can't make medical decisions based on what you see. The recommendations are always, if you think you're picking up an arrhythmia, you need to confirm it with some other kind of monitor before you act on it. And you have to remember, any kind of noise with some of these systems, like a LiveCore system, it transmits between your fingers or whatever, where you're holding that device in your phone, through sound, through sort of signals it sends through the sound. So if you're in a noisy environment, that can give all kinds of fake signals. So I think arrhythmia, whatever, rhythm unknown, is just sort of a grab bag for probably you have a lousy recording. And these are not medical devices. But Harry, what do you think about Apple Watches? You're a high-tech kind of a guy.
Well, I like the other aspect of it, where you're clearly having symptoms, and I want to know, is that because of your rhythm or not? So several people who quickly take a snapshot, text it to me and say, I'm having this, I'm feeling lightheaded, I'm feeling palpitations, what do you think? And the heart rhythms don't go normal. I said, that's not what's happening. So I tend to use it in a different way, rather than use it to diagnose, how you, basically it's a rhythm, symptom and rhythm correlation. That's how I use it.
So I think the point is, if you're feeling good or asymptomatic, there's no point really checking your watch, because you're not going to pick up anything probably that means much of anything. You're probably going to pick up noise. But as Harry points out, if you're having symptoms, it's a good way to catch the fox in the hen house. And then you can email the tracing to your physician, who can tell you what's going on.
Okay, Brittany, this is for you. Since intensive exercise can trigger or aggravate ARVC, at what age do you recommend genetic testing of children in families with a known ARVC mutation?
Yeah, this is something that we generally have a long discussion with families about, because some of it comes down to family preference and a family discussion. But in general, because we start our screening for ARVC around age 8 to 10, I recommend that at least by age 8 to 10, because then we know whether we need to subject them to screening or not. Otherwise, though, it really depends, especially in the US. There's a lot of push for very competitive athletics from a young age. So many parents are making that decision to know about the variant more around the beginning of school, when they may be enrolling in sports and things like that. So maybe 6 or 7, things like that. And some parents just want to know right off the bat so that they can guide things overall. Importantly, there's nothing we would do with this information in utero, so we don't recommend testing a baby for it unless you're going to make decisions about that pregnancy. We'd never recommend doing amnio and testing the fetus unless you're using that to guide the outcome of the pregnancy. And we don't even need to know shortly after birth. So long story short, family discussion, but usually be for, middle school.
Okay, Stephen, this is for you. And I can't say the name of that drug that you're studying, but it's about that study. The canamune, whatever. You say it so much better than I can. Is the hope for this to be curative or a way to slow or halt progression?
Yeah, it's canakinumab. It's so the very, very end of it, the MAB part, the M stands for monoclonal and the AB stands for antibody. So it's a monoclonal antibody that specifically targets IL-1 beta, which is a very potent inflammatory cytokine. So what I wasn't allowed to show, but I can talk about, is that the first study that we did with canakinumab was treating mice from our mice. So real quick background again, our mice have dysfunction at 8 weeks of age. And there's lots of paper that shows that you can have an electrical or functional phenotype prior to any of your cardiac remodeling, the fibrosis, the inflammation. So that's how our desmoglein-2 mutant mice actually develop disease. By 8 weeks, they have dysfunction. But the pathological remodeling takes almost another 8 weeks. So think of it like you have arrhythmias by 10 years of age, but by the time you're 18, now you're starting to have both arrhythmias, dysfunction, and now fibrosis. So that original study with canakinumab was treating patients, our desmoglein-2 mice, with the drug before they got the fibrosis. So our initial aim was to see if this drug will prevent or delay the fibrotic inflammatory, not fix the function, which was an outcome that did actually prevent cardiac dysfunction, which was a great finding, but it was specifically to try and prevent cardiac remodeling. So yes, it can prevent that, but the part of this second MTA proposal that Novartis, they pushed it. They wanted us to repeat the study to confirm and revalidate our initial findings. But they said this would be much more, for them, of course, profitable, but for our ARVD population, much more expansive if we could prove that this drug can help patients or our mice with end-stage failure. So think of the patient that's on waiting for a transplant. Would this drug help them maintain cardiac function after the fibrosis is set in? So right now the question is unknown. We know it can definitely prevent the fibrotic remodeling, but what we're trying to see is of that tissue that's remaining, can it revitalize the non-fibrotic? So that's the second proposal that Novartis wants us to do.
Great. This can be for anyone. What is the general prognosis with ARVC or life expectancy?
Well, that's a good question. And I think it certainly doesn't increase one's life expectancy. I think it shortens one's life expectancy. But I think in most patients, it has very little impact. There's some patients that have a severe form of the disease that get heart failure. And certainly those patients, there's no question it's gonna change your life trajectory, whether it's 5 years or 10 years or something like that. You won't probably live till you're 100. But I think for most patients, it makes very little difference. It's really the ones that present early as a teenager, particularly with severe disease as a teenager. They're the ones that are going to go on to develop more severe heart failure 20, 30 years later. And some of them will lead to transplant, and development, needing a transplant will shorten your life expectancy. Having severe heart failure will shorten your life expectancy. The good news is with use of defibrillators, the problem of sudden death is largely eliminated. So in this day and age, it's very rare for someone to die suddenly at a young age, provided they're protected with a defibrillator or they've been properly risk stratified. So I'd say it certainly does make a difference, but most patients live long and happy lives. But the reason we want to diagnose patients early and get them to stop exercising before the disease shows up is that's the best way to make sure it won't affect your life expectancy, is just be a gene carrier without manifest disease.
And you brought up heart transplant. So when is it considered to be time for heart transplant? Are there specific criteria that must be met first?
The answer is absolutely. There's enormous criteria. The whole process of being screened for transplant is extremely vigorous, and there's a shortage, obviously, of hearts. So they need to be sure that only the patients that absolutely need it get hearts, and the ones that don't need it, don't. So we work, closely with the heart failure experts. And when we start sort of seeing your heart function starting to decrease, we get them involved early. As Brittany will tell you, we start doing metabolic stress tests to sort of screen for how you're doing, and we really rely on our heart failure colleagues to make those decisions. But Brittany, what are your thoughts? You work with a lot of patients as they go between the heart failure people and the arrhythmia people, and you have a good sense of this, I suspect.
Yeah, so I think the bottom line of it is that it, as we've discussed with Dr. Galotra, with many patients, is that you want to make sure that your physician who is considering you for this has or is connected with people who have some experience in Rbc heart transplant, just because they shouldn't be trying to fit you into boxes like traditional left-sided heart failure patients or traditional heart transplant patients. Arvc is a little tricky because it's right-sided. The criteria don't fit very well. You kind of have to make a lot of exceptions, a lot of very proactive parts of your heart failure team. And many of our patients, they seem to be going along fine, and then things can progress very rapidly. So Dr. Galotra, I know, is very aggressive about monitoring and trying to transplant our patients before they completely crash. So I would say exactly what Dr. Hawkins said, but I would just make sure that your team, A, has a plan for monitoring you. We see way too often patients who just get their device checked every 6 months and don't have any sort of monitoring for cardiomyopathy, and that's really dangerous. But you have a physician who is monitoring you, and they're hooked into an advanced heart failure team that they can handle these types of evaluations.
I mean, the good news is in the old days, a very common reason for transplantation was intractable arrhythmias, intractable VT. And now that's basically unheard of. Harry's gotten so good at VT ablation and the sympathectomy. It's almost never that we have to send a patient to a transplant because we can't control their arrhythmias. So that's why it's really a heart failure issue and not an arrhythmia issue, because we're on top of the arrhythmia things much better. Harry, did I get that right? Do you have any comments on that?
Yeah, I just want to add that the focus in Arvc has shifted more to quality of life rather than the longevity. Because if you think about it, it's not like diabetes. It doesn't get multiple systems. One system problem. It's a system which is basically it's purely a heart failure issue or an arrhythmia issue, and that pertains to the heart. So we fix it as long as you can fix it, and at the time comes, you can get a new heart, replace it and get a new heart. So really the focus right now has been about quality of life and identify change in your quality of life early, and to intervene and keep track of the progress and intervene and get a heart transplant whenever you need it. So that's very careful monitoring, as Brittany suggested. I think most people have a fantastic quality of life moving forward.
Mm-hmm. All right, so I think this is sort of Cindy and Brittany can tag team this based on what we know clinically and from our research. Can you talk about women with Arvc and pregnancy? Would you ever recommend a woman with Arvc not become pregnant?
Sure. Why don't I start with that from a research perspective, and then Brittany can sort of address it day to day, the conversations you have with women we see all the time. So this is something as a research team we worked hard on to answer several years ago. We worked with our colleagues in the Netherlands and put together sort of the largest cohort of childbearing age women with ARVC. We tracked pregnancies women have had, both while diagnosed with ARVC as well as pregnancies they may have had before they were diagnosed with ARVC. And on the whole, really, the news was quite good. Of course, there were a couple of women who had arrhythmias during pregnancy. That's not terribly surprising. There were 2 women out of our group, both of whom had significant left-sided disease going into the pregnancy, who developed first symptoms of heart failure. So that was something to keep an eye on. But on the whole, everybody delivered their babies successfully. All the babies were well. There was a slight decrease in birth weight in women who were taking relatively high doses of beta blockers. But on the whole, it was a good news story. In answer to the question, are there any situations in which pregnancy wouldn't be a good idea? Certainly, there were those cases, and you saw hints of it here. But certainly an ARVC patient with biventricular disease or left predominant disease with very reduced left ventricular ejection fraction, that would be a high-risk pregnancy. And then I don't remember necessarily all the nitty-gritty of some of my prenatal genetic counseling training, but certainly there are medications like amiodarone that if a woman was on, you'd want to not be on amiodarone while pursuing a pregnancy, and there's other drugs like that as well. So Brittany, do you want to take it from here?
Yeah, I think you summed it up well, that our general consensus is that pregnancy is safe for ARVC patients in general, and that our patients do well, especially, as you said, Sydney, if you are stable and you kind of make a plan ahead of time. Patients with significant heart failure, there are concerns, as with other heart failure patients, about it progressing your heart failure. But luckily for most patients with ARVC, you're not in significant heart failure. And as long as your arrhythmias are stable, we usually recommend you stay on your beta blocker, because it controls your arrhythmias during the pregnancy and is largely safe. We can talk about meds and things like that. But then also, it's a very personal decision if this is something you want to do, and we can talk more about, that whole process, things like that. But the general answer to the question is that we try to be very supportive, and we've had really good outcomes in our patients.
Great. Here's another group effort question. I think will probably involve Tari, Brittany, and Stephen. Maybe you can tackle on some of your research in animals. But is there a significant correlation between an increase in anxiety and PVCs? And in addition to therapy, are there anxiety meds ARVC patients can safely take?
Yeah, there's certainly an association between anxiety and PVCs. It's a two-way street. PVCs cause anxiety, and anxieties can result again in PVC. So you really can make it happen by getting anxious. But again, the anxiety makes more adrenaline happen in your circulation, and that's one of the potent stimulants to increase myocardial excitability and thereby cause PVCs. I would highly recommend any sort of treatment towards anxiety, whether it is, yoga, meditation, including any medicines that you can take to reduce your anxiety, because that has a significant impact on, the quality of life in the RVC, and also occurrence of arrhythmias down the road. So any which way you approach this problem, and it's not that we're trying to characterize this as a psychiatric problem or something. It is attending to anxiety is at the core of treatment of arrhythmias in ARVC. So I really strongly recommend specifically addressing this issue in people in ARVC.
Yeah, and I would just tag on that this is something that we talk a lot about, that addressing your mental health and the anxiety that almost every single patient that we see has, is a really key part of ARVC management. And I think the big important thing, especially for a lot of people that I talk to that are like, oh, I don't want to take drugs, I don't want to rely on drugs for this or that. There are a lot of, non-medication ways to manage anxiety, but for many patients, drugs can provide a short-term solution to get you through the best cure for anxiety and post-traumatic stress, especially related to shocks and arrhythmias, which is time. Sometimes time and time free of arrhythmias can really help these things, and medication can get you through that. So I don't think you need to think of it as signing yourself up to be on these drugs for a lifetime. It's more about managing periods of time, and it's a critical pillar of our management.
Stephen, do you want to add anything from your research in your mice about psychosocial stress?
I'll have two things to add. Yes, I have some preliminary research that I don't want to talk too much about because it is in Journal of Clinical Medicine. So before it's peer reviewed, that would not be ethical of me to make any strong correlations. But anecdotally, I'd like to follow up on what Brittany and Cindy said about the inherent knowledge of knowing you have a cardiac disease. Of course, will cause stress in your life. I personally dealt with my first seizure I've ever had in my entire life in October 2019, this last year. And this goes into what Brittany was saying about treating your anxiety in moments of time while you're dealing with this. I had dealt with a lot of PTSD when I found out I had a seizure disorder and that they needed to remove a 7x4 centimeter tumor out of my head. Think about it, that's like 2 golf balls. And I dealt with a lot of PTSD for 6 months, and I saw a psychiatrist, and I dealt with the anxiety that I needed to deal with, and I got off my anxiety medication in May. And there's nothing wrong with that. No patient should ever feel that they should be embarrassed by that. They are learning something that they'll have to deal with the rest of their life, and that is both admirable and scary. And so I think that there is clearly going to be a lot of evidence that comes out that yes, there is a correlation of potential arrhythmias with moments of anxiety. And I think that that's just a way of treating that with medication, as well as what Hari was saying as well, that also yoga or meditation or mindfulness, also admitting to yourself you have it, knowing you won't be controlled by it, is also a form of meditation itself too, feeling empowered. So that's what I have to say.
Thanks for sharing. All right, Hugh, in PKP2 patients who have very low blood pressure and managed on high-dose sotalol, are there other treatments outside of ACE inhibitors to reduce the progression of ARVC?
The best way to prevent progression is to stop exercising. That's been shown. All centers all over the world have reported that. So when it comes to progression, I think the most powerful tool is really cutting down your exercise. The second important thing, which is a little bit unproven, is the ACE inhibitors. Whether beta blockers just control arrhythmias or prevent progression, we aren't sure. I should say that studying progression is difficult, because everyone's at a different spot, and we've sort of tried to think about studies to look at it. It's basically a very difficult problem. We know what happens. We know people have different rates of progression. We know now that there's these hot phases in ARVD where you may get a superimposed myocarditis, where things may progress, sort of in a stutter step fashion. It's not all continuous and gradual, and we don't fully understand these hot phases. The issue of inflammation, I think we're all recognizing, is more and more important. But what triggers the hot phases, and what can we do to cut those down? Because those probably, precipitate more rapid progression. So the answer is we have a lot to learn about progression, and I hope someday we'll be able to study this more rigorously. But at this point, there's very little data. But certainly the one thing we know best is the exercise piece.
All right, Cindy, I'm going to send this your way. Can you speak about the potential of Crispr in ARVC research?
So the potential of Crispr in ARVC research. So CRISPR is a really useful molecular biology tool. And so CRISPR is particularly helpful in a line of studies that some of you have participated in as part of our ARVC team research led by Les Tung, who's a colleague here at Johns Hopkins in biomedical engineering, or some of the colleagues we've seen at ARVC seminars in the past. So people like Joe Wu and Jeff Safetz, Mario Delmar, who you've met. And so in an iPS cell study, what you're doing is you're taking tissue from an ARVC patient or a family member with a pathogenic mutation. You're reprogramming that blood cell fundamentally to become a heart cell in a dish and growing it up. What CRISPR can do is can specifically target pieces of DNA to either insert or remove particular DNA sequences, particular mutations. You can think of it as a little pair of scissors that can snip in or out the mutation. And that's really a really powerful tool if you're doing molecular biology research. And so in these iPS cell studies, CRISPR is part of best practices to prove, for instance, that a mutation has the effect you really think it does. You can clip it out and clip it back in. Chuck, I know you've done some of this work as well. I don't know if you have anything to add to that.
Well, I think it's amazing that they gave the Nobel Peace Prize to the woman who helped invent this, because they should have given it to Rosalind Franklin for getting finding the double helix in the DNA, but that was stolen from her. So that's my first thing I'd like to say. But Cindy's completely correct in saying that the CRISPR technology is amazing, and it is being tested right now at Hopkins, part of a program that me and Cindy are part of, using iPS cell lines. So we create an iPS cell line from a family right now that has a DSG2 mutation. We've created their iPS cell lines, and they are sick cells. What we've also done is we've created a CRISPR-corrected cell line. So that same DSG2 mutant cell line from a patient, we've been able to fix that correction in a dish. We all have to think about the repercussions of putting a virus, because that's what it is, a virus that can cut DNA into the body, and think that it's only going to go fix the heart mutation. No, it's going to go cut up every area that has a DSG2 mutation in it, and that is highly in the skin and the intestine. So it's just a matter of time when we can use CRISPR-corrected technology to target one organ system before we just let it loose in the entire body.
All right, so Hugh and Hari, how many ARVC patients need to be paced? My husband requires 55% atrial pacing. How often do you see pacing?
No, I think the need for pacing generally is extremely rare, but where pacing comes in is someone has resting sinus bradycardia. They have a slow heart rate. They put on a beta blocker to control their arrhythmias. The beta blocker slows their heart rate further. And if that causes a heart rate that causes them to be symptomatic, meaning they're lightheaded and their heart rate slow, well, that can be corrected by putting in a pacemaker or adjusting the dose of the beta blocker. In general, we prefer to put in either subcutaneous defibrillators or single lead defibrillators rather than dual chamber defibrillators, because the more hardware you have in your heart, the more leads you have in your heart, the higher the chance of an infection, of something breaking and a problem down the road. So in general, we tend to recommend single chamber pacemakers, and we program them to an extremely slow rate. So even if your heart rate is somewhat slowed from a beta blocker, it's not slowed so much that you're pacing in the lower chamber. So the answer is, some people need it, but I think it's a small percentage, probably about 10%, something like that.
I'd like to add to that, saying it's also depends upon how it's programmed. If you program your lower rate at 60 beats a minute, and your native heart rate is around 50 or 55 at night when you're sleeping, your atrium is still being paced. And if you go look at the pacemaker, it could say 50% of the time you're being paced. It is more of, how you programmed it resulted in that atrial pacing. But in somebody who's taken antiarrhythmics, who's taken either sotalol or flecainide or amiodarone, they may have a slower sinus rate, which also increases the amount of pacing. So I think there are a lot of different situations which explain why somebody would pace in the atrium. But in general, that's mostly because of something that's happening overall, like an antiarrhythmic drug or the way it's programmed, and it's really nothing to do with the ARVC.
I think it's also important. I think a lot of people have the sense that pacing, if you increase the heart rate, pacing the heart rate faster somehow will be antiarrhythmic, that will prevent arrhythmias. And there's very little data to support that. So the notion of pacing your heart at 80 beats a minute, so that's going to suppress your PVCs or suppress your arrhythmias or prevent sustained VT, I think that's totally unproven. That may be true in long QT syndrome, which is a totally different disease. But in ARVD, we don't think pacing itself is antiarrhythmic. It's not going to prevent arrhythmias.
All right, here's another tag team question from our genetics professionals and our EP docs. What is recommended screening regimen for asymptomatic children of a father with negative genetic testing, but severe ARVD and ICD and multiple shocks?
I mean, in general, if you're a gene elusive family like this, where we don't know the mutation in the program, the first person diagnosed, then all first degree relatives should be screened. And the screening frequency depends a little bit on how much exercise that person's doing. But in general, we say every year you should get an EKG and a Holter, and every 2 to 3 years you should get your cardiac function checked with either an MRI or an echo if you don't have high quality MRIs available. If you're exercising a lot, we would probably screen even more frequently. If you're exercising very little, particularly if you're older, once you get to be 40 years old or whatever, and you haven't gotten ARVD and you're not exercising, then I think the frequency of screening can be extended. But Cindy, what comments do you have? You've written some papers on this.
Yeah, I mean, I think there is the potential in the future as we learn more to personalize screening based on family genotype, which is exactly the question being asked, but we're not there yet. And certainly all the guidelines that have been published promote the same screening regimen for gene positive and gene elusive families. I'm pretty sure. Brittany, correct me if I've got that wrong.
Yeah, all the formal guidelines. There are some recommendations that allude to that if you don't have a confirmed mutation, that you could possibly back off family member screening based on reduced penetrance in family members. But it really depends on the person who presented and how, you said it's severe, but how early did it present? What does it look like? What was their exercise burden? Are we confident that this may be, how genetic, what contribution do we think genetics may have played to his disease? And then also making sure that he has had the absolute most up-to-date genetic testing. I talked about in my ABCs talk that especially if you had negative genetic testing before 2012, you should definitely have repeat genetic testing. So I'll just throw in that one little plug as well.
Hugh and Hari, are there any recommendations for monitoring once a patient is on flecainide for ARVC? So any specific monitoring of flecainide?
I mean, in general, if you're on an antiarrhythmic drug once a year, you should get your EKG checked, and you probably should check your kidney function because flecainide is excreted by the kidneys. But that's it. There's no other specific recommendation. I mean, flecainide is a very simple, safe medication. The main group of patients we can't use it in are those with ischemic heart disease, those that have had a heart attack, particularly if have decreased function. You can't use either flecainide or propafenone in that subset of patients, but almost no patients with ARVD have coronary disease, so it's rarely an issue in our patient population.
All right, has there been new research which shows how AFib might relate to ARVC?
There's been a lot of new research on the link between AFib and ARVC. We were one of the first to write a paper describing that about 20% of ARVD patients get AFib. And then the group in Zurich has done some nice work replicating those findings, but also doing more investigation, looking at the atrium itself and atrial tissue. And I think, whereas in many years ago, people thought ARVD didn't affect the atria at all, I think now people realize it does. And so that is a real part of ARVC. But Harry, do you have any thoughts about AFib and ARVC patients?
I think in general, what I've seen is that most patients with ARVC and AFib tend to be kind of older. So it's uncommon to see younger patients with ARVC and AFib. So it's like it catches up, I think, once you start getting into your 50s and whatever. There's a certain subset of population who will develop AFib. Clearly, having a mutation that increases fibrosis in your heart, kind of interacts with that, and you probably have a higher incidence of AFib than the general population.
All right, here's a genetics question. Is it recommended to do genetic studies for the children of a deceased by ARVD who could not have a genetic study?
Generally, no. Genetic testing and using asymptomatic family members as surrogates is very dangerous because of the complexity of genetics. You can find variants that you're not sure what they mean. They can be misinterpreted when you don't have a clear phenotype to compare that to. That being said, it depends on what those other individuals may look like. Are there slight abnormalities that we want to track and do genetic testing? I really recommend meeting with a genetic counselor who has expertise in cardiac heart disease, who can work with you to comb through your family history and see if there's anybody who may be appropriate for genetic testing, and or to work with the medical examiner, especially if it was a recent death, to see if there was any sort of sample saved. I've done this many times over the years, that we've called the medical examiner and found something that was found, and we were able to do autopsy genetic testing, which has a much higher degree of accuracy and is actually going to tell you what you're looking for, rather than potentially bringing up a bunch of junk that can be misinterpreted.
All right, Cindy, can you comment on the penetrance of ARVC in patients who minimally exercise?
So the penetrance of ARVC in patients who minimally exercise. So I'm going to assume we are talking about an at-risk family member, because penetrance is a concept, which means if you're born with an ARVC-associated mutation, what are the chances you're going to develop disease? That's what penetrance means. And so, again, like in so much with ARVC, we're still working on the data, but we've recently finished a study of 100 family members. So not the probands, only the family members with an ARVC-associated mutation. And we looked at the exercise they'd done really from age 10 until however old they were when we did the interview. And it certainly looks like that individuals exercising at or below the sort of AHA recommended level of exercise for healthy adults had something like a 5% in our data, a 5% chance of going on to develop ARVC, while individuals exercising a lot more than that had a substantially higher chance. So again, that was one person out of 20. That's how I'm getting my 5% number, but it's substantially lower than for individuals who exercise a lot, at least in families with PKP2 mutations.
All right, Hugh, can ARVC patients with allergic asthma safely use salbutamol or similar drugs that act antagonistically to beta blockers?
I mean, in general, I say it's fine if you need to take salbutamol, some of these drugs that are alpha agonists or epinephrine-like drugs. It's very unlikely that's going to trigger arrhythmia. I mean, in patients that are high risk for arrhythmias, they're protected with a defibrillator. In patients who are low risk, well, they're in low risk whether they take a sympathetic drug or not. So I say if you need it, take it. Quality of life is important, and if it helps your symptoms, it's worth taking, and the risks, in my mind, are extremely low.
All right, we're going to take one last question, and this can be for anyone. Do you think there will ever be a cure for ARVC, and how long?
Oh, I'm sure there's going to be a cure for ARVC. I mean, I'm an optimist, and I think the future's bright. And this program was set up, and one of our goals is to cure the condition, whether it's through a genetic-based approach. I mean, I would think there's got to be hope for a genetic-based approach where you have the mutation, you go in there and you fix it with whatever CRISPR or whatever, and snip it out and put in a good version. I would think that would be the answer. So I'm very optimistic that a cure is on the horizon, but I'll turn it over to the rest of you to weigh in.
I would say also, I think just looking at perspective, you know, and we think year by year seem to go by slowly. Some years, like 2020, slower than others. But, you know, if you think about clinical genetic testing for these genes wasn't even around at all until like 2006, 2007, and how far we have come in that short time since then. I think we're going to have huge breakthroughs, you know, in the coming years, if you think about how far we've come just in that time. So I would say optimistic, although not in 5 years.
Well, I like to add something to this. That the most thing about we heard in 2020 is that a cure for COVID, right? That's the only thing we heard. And slowly we're understanding that, you know, it's not about jumping for the cure, but first of all, let's manage the situation. Let's first learn to live with it. Let's learn to be more comfortable with it. And let's learn to conquer the heart failure aspect of it, the arrhythmia aspect of it, and make it a non-issue to begin with. And then, yes, eventually, as science will progress, we'll identify how to snip and clip and everything else, and we'll get there. But in the short term, at least in our lifetime, we'll make a lot of, you know, headwind in controlling all the symptoms. So it becomes pretty much a non-issue, like managing any high blood pressure or diabetes. And that is our goal, to make it something so palatable, whatever, so that it really doesn't interfere with your quality of life.
Yeah, I'll weigh in with and really echo both what Hari said and what Brittany said. Last year, we had the opportunity to have our 20th anniversary of the Rbc program. And as part of that, we put together sort of a retrospective look back. And certainly, and I know certainly if you were diagnosed last year, this 20-year perspective is not especially maybe personally salient. But if we look at how far we've come and how rapidly we've come, I'm also optimistic. That said, cure is a big word, but I think management to the point of this really not impacting your day-to-day life is an achievable goal. And I certainly know things have changed a lot in the last 20 years on that front.
I'll add my 2 cents in. I'm a researcher. I have a PhD, not an MD, so don't take my advice. I'm not a clinician. That said, I think that unless we start doing CRISPR in humans, which I really do believe will happen, I really do believe that eventually we'll get to there, that we'll never be able to fix the mutation that's present. So I really do believe it's all about precision medicine. It is knowing what each specific patient needs at that specific time. Maybe you just need watching, you know, I mean, maybe it's just you get an annual, you know, MRI or an echo and you don't even need to take anything. But maybe you need to take a beta blocker plus an ACE inhibitor. Maybe you need to take a beta blocker plus potentially canakinumab. So there's all these different things, I think, that for like what Hugh Calkins was talking about, that there are hot phases, you know, so maybe during a specific time with a specific mutation, with a specific patient, this is why there's a team of people. You don't have one physician. You have a physician. You have a heart failure physician. You have an EP specialist and genetic counselors. And so it's a mixture of, I think, precision medicine for one specific patient, and also all of that together with not only the clinical and medication lifestyle changes. Patients really need to get on board to help their management as well. I can no longer drive legally anymore because I have an epileptic disorder. Patients with ARVC need to stop asking questions whether or not is it safe to exercise. It's not. It is not safe for me to get behind a wheel of a car because I might hurt someone. You should not be getting and signing yourself up for a marathon. You know, you need to follow the advice of your physician, your team, actually. So that's my hope. CRISPR eventually, right now, management, precision medicine.
And of course, we can't make any progress without you, the patient. So we appreciate everything you do to support our research. We want to continue to partner with you, and so we thank you. Hugh, do you have any closing comments?
No, I just want to thank everyone, all the speakers and faculty for doing a fantastic job, and all the patients and family members that have signed up. This is a totally new initiative for us, and we thank the SADS organization for allowing us to dovetail onto their conference. But we're all about education, getting the message out. We're with you on the journey. We want to ultimately cure ARVD, and we'll keep working hard every day to make the world better from an ARVD perspective. And I remain optimistic. And again, thank you. And let's pray that this COVID disappears ASAP. We're all sick of it, and we want to get back to our in-person meetings and seeing you all. And don't forget about our conference this spring. We'll have one of the best ever, and it will be virtual.
All right, guys.